Okay, well, hi, everybody. Thank you so much for coming in person. Thank you, those of you who are joining us online. It is my great pleasure as the chair of the search committee for the faculty search for the the Hubert Department of Global Health to welcome Dr. Felker-Kantor. Erica joins us from Tulane University, and she is currently a social epidemiologist with Population Services International, and a member of the Department of International Health and Sustainable Development in the School of Public Health at Tulane University. So, Erica, without any further ado, welcome. Thank you so much for joining us and look forward to your talk.
Thank you. I just want to say first, thank you to the search committee for inviting me here and all the faculty and students who will be meeting with me or already met with me. I know everyone's very busy, so I appreciate your time. I think I'll talk for around 35 minutes or so and then have time for questions. And I've divided my talk into 4 sections. First, I just want to give a brief overview of who I am and how I arrived to where I am today. And then I'll spend most of the time talking about my current research and some future research interests. And then finally talking about my teaching philosophy and my fit with Emory. So my initial interest in global health really came about when I was doing my first master's degree in Latin American and Caribbean studies, and I was conducting my thesis research along the Haitian-Dominican border, where I was really studying the factors that were influencing healthcare seeking experiences for Haitian pregnant women who were delivering in a Dominican border hospital. And it was really this experience that got me interested in the social and structural determinants of health. So I decided to do an MPH at Hopkins, and then that was followed by several years working at the CDC as an epidemiologist, primarily in Haiti following the 2010 earthquake. When I was at CDC, I noticed that a lot of the public health programs that were being implemented were rarely addressing these broader social and structural factors that were clearly playing a role in one's ability to access care, the quality of care that they were accessing, or quality of care they were receiving, as well as their health outcomes. Eventually, I decided I wanted to get a PhD really to further my methods and technical skills, but also really to further my expertise in the understanding of the processes through which these social and structural determinants are impacting health. And during my PhD, I worked with Dr. Thiel, who really exposed me to the works of several scholars who were questioning the notion that individual responsibility and biological differences were explanations for health disparities. I became interested particularly in neighborhoods and social networks as determinants of health and how they may contribute to health inequities. I continued this line of research through my doctoral studies, my postdoctoral fellowship, and even some today in my current positions. And I'm going to present some of that research today. So very briefly, for those of you who aren't familiar, this is the social ecologic model. And the social ecologic model really conceptualizes health broadly. And it emphasizes that multiple levels and multiple factors can affect one's health and one's health behaviors. And 2 of these important factors are place and social networks, which are of my interest. So what do we really mean when we say that place matters for health? Well, first, let's define place. So I would define place as the environments in which we live, work, play, and grow. And really over the past 30 years, there's been a large body of research that has emerged showing that the social and physical environments of where we live is strongly associated with health outcomes, including chronic disease, adverse birth outcomes, mental health, and a number of other key indicators. How does the social and physical environment actually impact health? And there's many different pathways through which this happens, and one is really through an induced stress response, right? So you're exposed to these disordered and toxic environments, and this can induce a stress response, which then can have an impact on your health behavior and your health outcomes. Now, traditionally, when we measure sort of place-based effects or neighborhood effects, we use like predefined administrative boundaries really as our definition of a neighborhood, right? But there's some limitations to this approach. One of those limitations is that it doesn't account for mobility, and it also doesn't account for exposures outside of that predefined administrative boundary, right? And by not doing that, we are at the risk of having inaccuracies in our measures of exposure. So one approach that's come about is called activity space research, activity space mapping. And what this is really just the examination of all spaces in which daily activities occur. And it's thought that this approach provides for a more precise and operationalized exposure measure about the more complex human spatial movement. And I have an example here. Here is a map, the bottom map of, this is from a study we did a while ago. But what you see is one participant's activity path. And this was over the course of 2 weeks. And so what we did is we have GPS or a smartphone app that can basically download every 60 seconds where someone is. And then we can recreate this path. And what you see is this person is exposed to many different environments outside of just their home residential tract, which is indicated by a little star. It's a little bit small, right? And so again, by using an activity space approach, we're able to capture exposures in a more complete way rather than just defined by a little census tract. So in addition to place, we know that social relationships also impact health. And social networks, and when I talk about social networks, I'm not referring to like media, but well, some of the youth, really young people may think that it's the people with whom you interact, right? And social networks are thought to influence health through several pathways, social support, social influence, access to resources. And really, there's been a large body of research within sort of the HIV domain that's really shown that social network structure and size are key predictors of HIV risk and other behaviors such as concurrent partnerships and drug use. So we have the evidence that social networks impact health, and we have the evidence that place impacts health. But there's less known about the intersection of the two. And that's really what I was interested in doing in this research. Networks and place are often studied independently. However, we know that social relationships play an important role in where people go, and in turn, what environments they're exposed to, right? Likewise, where people go may facilitate the fostering of new social relationships and the changing of one's social network structure. So by directly examining the link between social networks and place, we can develop a better understanding of the processes through which environments shape health and contribute to health inequities. And I'm going to present here my research, which aimed to do that. And so my research aimed to really examine and assess the joint effects of daily activity spaces and social networks on daily drug use among female sex workers with HIV in the Dominican Republic. So we had three aims, and the first aim was really just to describe these daily activity spaces and then to see if there was an association with drug use. The second aim was to characterize the social networks of female sex workers, and then again, test the association between your social network structure, and we were particularly interested in risk network. So we wanted to test the association between one's risk network structure and drug use. And then the third aim was really to examine the interaction of the two on drug use. So I'm just going to walk you briefly through the conceptual model so you kind of have a visual of what I'm talking about. I'm a visual person, and so I think conceptual models are very helpful. So what you see here is on the right, these are the exposures. And then on the left, we have our health outcome, right? And so our two health exposure, or our exposures are activity space, risk environment, and we have our social networks. And what we posited was that female sex workers with higher exposure to these risk environments within their activity spaces would be at increased risk for drug use. We also posited that female sex workers with riskier social networks would also be at increased risk for drug use. And why does this really matter? Well, we all know drug use is a salient determinant of suboptimal HIV disease management and antiretroviral adherence. So to achieve sort of our understanding and to meet these aims, we employed a micro-longitudinal observational study. And again, this was with female sex workers with HIV. We attempted to recruit half who are drug users and half who were not. Our final analytic sample was small, 51. This was a pilot study. But because it was repeated measures, we ended up with 326 observations. Now for aim one, we needed to get data on risk environments. And in the US, that's often accessible through the census, health, state departments, where you can get access to area level exposure. So for example, you could get crime rate, right, by census tract. In Dominican Republic, this just doesn't exist. And so we had to come up with an alternative approach. And so we did self-reported risk environment mapping. And what this was we used Google Maps, and we had the female sex workers identify and rate the riskiness of locations within Santo Domingo. And they rated it according to high, medium, and low risk. And then they specified what type of risk, was it drug use, or was it police violence? Was it poverty? And so that was one way to get this risk sort of exposure, this environment risk exposure. We were able to obtain some secondary data of risk outlets. And so what this was there was a study that had been conducted previously who had mapped across the country risk outlets. And they had categorized risk outlets by things such as hotels, bars, drug spots, drug markets, certain sex worker venues. And it wasn't all the places, but the ones that had been sort of rated as risky. So we were able then to combine these two sources of data, right? This risk environment data, that was the self-report from the female sex workers, but then also this secondary point data of risk outlets. Now, to get our activity space, as I mentioned, typically in the US, we'll use a GPS or a smartphone app that can track, where you're going, and you can easily reconstruct someone's path. During formative research, we found that first, not all sex workers had a smartphone. And then second, due to the sensitivity of their work and the riskiness of their work, they were really hesitant to use, a smartphone tracking device. And so we had to come up with a different approach to collect this data. And so what we came up with was sort of a daily travel diary. This is in Spanish, but basically what we did is we asked them to report all the locations they went from the time they woke up to the time they went to bed. And this included also the time that they spent at each location, if there was alcohol, drugs, or danger in the location, and then what they were doing at that location and how they got there. Was it by was it by car, or was it by moto or walking? Because all of that comes into play when you're calculating time exposed. And so they had one of these for 7 days. And then after the 7 days, they came back in and we sat with them and we basically plotted all of the locations that they had written down. And that's how we created their.
It's done at the end of the day or in real time?
So this was done. So they did this every day for 7 days and then they came back in.
Effectively, you did fill it out.
Real time. And then at the end of the day, they sent us a WhatsApp photo so we could see that it was completed. Yeah, so that's how we created these paths. So for AIM2, for the social network data, we used your traditional sort of social network name generator. And this is really just a bunch of questions that helps the participants think who's in their network. And we had specific network types that we were interested in, such as emotional support network, their sexual network, their drug network. And so we use these generating questions to help them list out the members. And then for each person they list, you have to collect attribute data, right? So characteristics and behavior of the people within their network. And then finally, we ask them about who within your network knows each other. And then we can take all of that and create network level variables. And for our AIM3, it was really just statistical analysis through effect modification in adjusted models to look at the joint effects. For our behavior, we used a daily behavior diary, and this was sent via WhatsApp once a day for 7 days. And this collected information on, drug use, what types of drugs, alcohol use, how much, antiretroviral adherence, and a number of other sort of behaviors. So I'm going to just briefly present the different aims, the results of the different aims. And so here we have aim 1. And before I go over the results, I just want to walk you through the maps so you kind of understand what we did. So the map on the right, this is one female sex worker's weekly activity path. And so we took all the information from those diaries and were able to create this activity path. And then we can overlay that on the risk outlet data. So you see the little red points, that's all the risk outlets. And then we're able to look at exposure within the activity path to those risk outlets. And we took into consideration other things such as time exposed, and we did this within buffers. So we did it within 100 meters of their activity path, 200 meters of their activity path. So we could get, sort of a calculation by distance as well. And then on the very left, we have something similar, but it's not an activity path, it was activity locations. And so what we did is we plotted all the places they went and then created buffers around those locations. And again, looked at exposure to risk outlets within that buffer. The middle map is the self-reported risk environment data. And so what we see here is the red is the high risk locations, orange and yellow are medium, and then green is low risk. And again, we're able to then take the path and plot it over these risk environments and calculate exposure. And so what did we find? Well, we found that in adjusted models, we found that female sex workers who were exposed to more risk outlets within 200 meters of their activity path had an increased risk of daily drug use. We also found that female sex workers exposed to more risk outlets, specifically within 200 meters of where they engaged in sex work, was also correlated with an increased risk of daily drug use. Now, we thought that this could be not only because of not only could the drug use be used as a coping mechanism for the stress that's involved with engaging in sex work, but it's also possible that using drugs is a way to minimize the stress associated with exchanging or soliciting sex in areas where there's a higher concentration of these risk establishments, and in turn, higher likelihood of exposure to violence, drunkenness, societal stigma. Now for aim 2, the social network part, we found that the social network size do not vary. So on average, both drug using and non-drug using female sex workers had 11 members in their network. But what we did find was that among female sex workers who use drugs, 46% of their network members were drug users, compared to just 12% of non-drug using female sex workers. Similarly, we found that female sex workers with more sexual partners who were drug users, I think it was 21% versus 7% in non-drug users, right? And so again, not too surprising, who you're around is likely to influence your behavior. And you can see here that in adjusted models, we found that exposure to social networks with more drug users was correlated with an increased risk of daily drug use. Likewise, exposure to social networks with more sexual partners who use drugs was correlated with an increased risk of daily drug use.
Eric, while you have that up, where do clients sit here? They would typically fall outside of the normal thinking for a social network.
Yeah, we had
repeat clients.
Yeah, we solicited when we asked them to list out the names of the people within their sexual network, they included clients as well as stable partners.
This has a lot to do with habits and their own rationale and experience, right? And sometimes even the need to be closer to drug establishments. Did you ask the rationale behind why they went to certain avenues versus others, or any other kind of qualitative data that kind of contextualize people's risk paths?
Yeah, we did. We did qualitative data. So when they came back in and we mapped this, then we did collected qualitative data to better understand these sort of their paths. And why they went that way versus a different way. We did do that. Yeah. So for aim 3, which was really to look at the intersection, right, of social networks and activity space risk exposure on drug use, we did effect modification, and then we did a joint effects test. And we did find effect modification by social network structure. And when I talk about social network structure, we categorize this as high risk networks and sort of lower risk networks based on the proportion of people in your circle, your network, who were drug users or sexual partners who were drug users. And in stratified models, we found, it was actually interesting that activity space risk exposure was correlated with daily drug use for female sex workers with smaller drug or sex and drug networks. And the thinking behind this is that female sex workers who aren't exposed to as many social risks may be more impacted by their environment, right? Whereas female sex workers with larger social risk networks, right, that may play a larger role in shaping their behaviors than the physical environment. Our joint effects test did find that the joint effects of these two factors was greater than each one alone. So we did all this interesting research with different methods, and I guess the question is, so what? What do we do with this? And so we had like a debriefing with the female sex workers, as well as with some of the other investigators, to really think about how can we use this data. So we came up with a number of different recommendations. One would be to look at creating more enabling environments that around their work or living space, as well as integrating sort of drug treatment and drug testing services into the HIV care service model, which it wasn't integrated at that time. There's a big movement for decriminalization of sex work in the Dominican Republic. Something that's happened in the US in some cities is they can limit the density of alcohol outlets, for example. And so that's another potential option. Of course, all of this would have to be in partnership with the government and, can become complicated. In terms of network-based interventions, I mentioned to Dr. Yem, we couldn't suggest that they break social ties with the drug users, because the clients who were drug users, that's what they depend on for their livelihood, right? And so we thought about potentially looking at sort of a positive opinion leader, or, a positive sort of role model within their network who's modeling healthy behaviors. In terms of limitations, of course, there were many. We had small sample size. We had self-reported measures, which lends itself to information bias. We had selective mobility bias, and the study wasn't really powered enough to do a lot of subgroup analysis. So that was that research. And I just wanted to present another type of research that I've been involved with recently. I thought it would help, for students who are thinking maybe of going the more applied route, that this is kind of an example of the type of research that we've been doing in an NGO setting. So a lot of the work that we've been doing is really around health system strengthening and provider-based interventions. We received funding from USAID to do a person-centered care intervention at 40 facilities for, I think it was 200 providers in Benin. And this was really just a number of modules that they were trained on around person-centered care. To evaluate this, we used a mixed methods sort of pre-post study design, and really tried to anchor it in sort of a implementation science re-aim framework, where we were looking at the efficacy, but also feasibility, acceptability, sustainability. And then we also decided to look at developing a client experience of care metric. Now, client experience of care has validated metrics, particularly by domains. And so the thinking was, could we develop a client experience of care metric that was sort of health area agnostic, as well as developing a short form of a metric? Oftentimes, the client experience of care metrics have a lot of items within them, and that can be burdensome to collect on a regular basis. So we wanted to come up with something that was short, that could be incorporated into routine monitoring data. And so we came up with a long form of this client experience of care scale, and it had 13 items, which had good reliability with an alpha of around 0.9. And then we used qualitative ranking interviews to help do item reduction. And so we had the participants report on the importance of these items by domain and by the item itself. And those with the lowest rating got dropped. So we ended up with a 6-item scale, which is in this table, and that's now been implemented into their routine data monitoring so that they can constantly see how client experience is evolving as they adapt services. And we did see an effect from pre-post of the intervention. And so it seemed that the intervention did lend itself to improvement of client experience of care. In terms of my future research, I have a lot of different interests. And a lot of them are really just anchored in my underlying interest in social and structural determinants of health. I'd like to continue doing some place-based and network-based work. I have been involved with a study that has been using geographic ecologic momentary assessment, which is really just a way to collect your behavior and your spatial data at the exact same time. So you can see where someone is and how they were feeling, for example. And then again, thinking about multi-level interventions that can address some of these social and structural factors. I want to continue doing implementation science research. I've really sort of enjoyed that process in my current role. I think it's important not only to think about just the efficacy of an intervention, but about the various steps throughout the process of implementing, and ultimately really the sustainability and acceptability of the intervention. I am interested in urban health, which kind of ties to my place-based interest. And I've done some work in informal settlements, and I'm interested in sort of continuing that, doing some community-based participatory mapping, and maybe using photo voice and developing sort of a disorder metric. I did want to note that with the sex worker study, the participants really enjoyed participating in the study because they were active participants. It wasn't just us asking them questions and them saying yes, no. They had to, think about place, they had to record, and they had to come back in and work with us to map it. And that really showed me sort of the importance of really engaging with your participants, and the importance of doing sort of community participatory research. And then finally, climate and health. And we were talking about this earlier. We know that as a social epidemiologist, I'm really interested in exposures, and climate is, directly and indirectly related to health. And so it's a new area that I'm interested in, trying to think about first how you're measuring climate, but also how it could relate to food insecurity and in turn, gender-based violence and care-seeking behaviors. In terms of my teaching philosophy, I really try to center my teaching around the belief that advancing health equity is really a fundamental role of public health. And I believe training future public health professionals really should be done through a health equity lens. And I use that lens to guide sort of my curriculum, the assignments, and our classroom discussions. I really try to create an open sort of participatory environment that provides both critical and analytical thinking, but also tangible skills that can be used, whether you're in academia or outside of academia. In terms of courses, I developed a graduate course, geospatial epidemiology course, and taught that for several years at Tulane, as well as research methods. I currently teach a research methods course to attending physicians and medical residents at a hospital in northern Haiti. And it's really based on quality improvement research. And so I've been doing that for, many years now with the different cohorts. I think I'd be well positioned to teach a number of different courses here at Emory. I'm interested in developing a social network analysis course. If there isn't one, I don't want to duplicate. But I think when I was doing my studies, I didn't have a course like that, and I had to go to outside trainings. And so I think that it's sort of an interesting methodology that students may be, curious about, and I'd be interested in developing a course on that. And then finally, why Emory and why me? So I think Emory is great in terms of having a diverse student body. I also think that there's just incredible faculty, right? And as a junior faculty, it's really important to me to have mentorship and collaborations with other faculty who are interested in the same type of research. And I think Emory has a lot of that. From doing all these different job talks, I've noticed that Emory really seems to value applied experience. When you look at a number of the professors, they have applied experience, right? In some schools, it's a straight academic, trajectory. So I really appreciate the sort of unique aspect of having faculty who've had experience outside of academia. And of course, Emory has great partnerships, both globally and domestically. For me, I think probably what I bring is kind of unique in that it combines sort of academic portfolio as well as sort of this many years of field experience in working with CDC, working with NGOs, USAID. And I think that can be helpful for students in that they can really kind of see how you can transfer skills from academia into a more applied setting, but also how you could take your experiences in the field back to your academic work. I'm a mixed methods researcher, but I do have sort of the subspecialty in geospatial and network-based methods. And I come with sort of a diverse network of both academic connections and also connections within the larger field of global health with different organizations, associations, which can also be helpful for students. And I think that's it.
Thank you, Erica. Any questions for Erica?
Or online, yeah.
I have a question. So I'm curious about for A1. So
Can you just introduce yourself?
yes, sorry. I'm Kamini. I'm a second year global health and development PhD student. And my question was about A1 and kind of the way that you categorize or the sex workers categorize the risk environments and the neighborhoods. I guess is it possible that the sex workers had a tendency to maybe scale down the level of risk for neighborhoods since they're usually that's the norm for them? And I'm curious what you kind of did to address the potential for bias that way.
Yeah, I mean, that's a bias of this having self-reported risk environment data. And so we asked them about just in general environments, not necessarily where they were doing sex work, but in general in this city, where is it more risky to live due to poverty, or where is there higher, where do you go to buy drugs? In terms of addressing that bias, I think that's a limitation of the study with the self-report, unfortunately.
Erica, thanks for the presentation. Also talking about your M1, M2 sort of. The study had 51 individuals, right? You talk about repeated measures. I'm not sure that really answers the question I'm going to pose, which is that I saw a list of about 15, 20 covariates in the model. And where I came from, that sounds like an overfitted model, right? And therefore, I don't trust the estimates from a model such as that. So
we didn't. So in the conceptual model, we listed out a number of different covariates and potential confounders, but when we did the modeling, we didn't actually include all of those in the final models.
What is the final model adjusted for?
I have to look that up. It's been a little while. Let's see. So we adjusted for, let's see, we adjusted for, I don't think I have it here. I'll have to get back to you. I don't have it on this slide.
One variable, I don't trust the estimates.
Sorry?
More than one variable, I don't trust the estimates.
Okay, well, it was more than one variable, so.
To take a slightly different theoretical approach. This whole modeling approach is based on a risk perspective, and you and I had a chance to talk about resilience and assets-based models. And so just based on your experience, what assets and opportunities for resilience exist within these communities that might be a basis for intervention? And then secondly, you very artfully sort of dismissed social media. And I thought that was very well done. At the same time, we work in environments, including with sex worker populations where access to smartphones is exponentially increasing already in the majority of the population. And so social networks really have exploded in ways that are not captured here. I wonder if you could address resilience and then how you would think about handling the increasing complexity of social networks.
Yeah, in terms of resilience, within the Dominican Republic, there is a large sort of national female sex worker association, and they actually have days when they, kind of have, we have National Pride Day, they have National Female Sex Worker Day, and go out and advocate for respecting female sex workers. This is their job. It's not, their identity. And then there's a number of organizations that sort of work together with the police and with the female sex workers, trying to protect them from potential harm that comes their way. In terms of most of the services, I would say a lot of it is really focused on HIV due to the nature of their work. But there's definitely potential partnerships where we could look at doing an intervention. And I've thought about cognitive behavioral therapy type of interventions around mental health and, social support. And I know that there's been a number of other researchers who I've worked with who've done interventions in the Dominican with key populations. In terms of social media, yeah, the female sex workers we were working with, not many had smartphones, but I do think that is definitely on the rise, and especially doing online type of sex work, right? And then also thinking about sort of what type of digital interventions could be effective for these groups. And one of the comments from the female sex workers was that they really liked sort of the daily diary because someone was like checking in on them and asking these questions. And so I think that also lends itself to potentially thinking about more social support type of interventions. We are actually in the study that I briefly mentioned where we're using geographic ecologic momentary assessment. We actually used our exploratory data to then inform the development of like an application, which really would trigger, like there would be a trigger when they were going to be in these more sort of dangerous environments. And then it would give them sort of some, tips or alternative routes or ways to sort of stay calm, address sort of their internal emotions. So that was sort of our attempt to try and use this geographic data to create more personalized intervention.
Erica, thank you so much for the presentation. Really, really interesting stuff. I want to go back a bit to the activity spaces. And I mean, I think it's a kind of implementation science type question. We were talking earlier about our mutual interest in Haiti and having worked in Haiti. One of the things that we worked on was mass grant administration program for us, where we ran into the problem that you surfaced there about census boundaries, and those census boundaries in many ways being sort of contested socially because they didn't reflect the realities on the ground. And we were working in a microplanning sort of approach and running into problems of people not participating because they were on the wrong side of the boundaries. So, I mean, that was the context that came to mind when you were talking about it. The question that follows from it for me is, how do you think about the application of these kinds of findings, for example, in implementation, say with a partner, say an administrative partner, like the Ministry of Health, or even a program that may have been working in conventions with more conventional boundaries? Have you thought about how you might sort of experiment with overlaying or doing comparisons of administrative boundaries? Or because I think you're onto something quite interesting. They're fundamentally different spaces than the ones that are defined administratively. So terrible question, but hopefully
No.
you get a sense of what you're trying to get at with that.
No, it's a good question. I personally have not, but I know that some of the work that some faculty in New Orleans are doing are working more with sort of the mayor and the local government, really trying to think. And of course, it's very bureaucratic in the US to try and change census boundaries. But they are trying to introduce this idea of, we can't really define, place just on this arbitrary predefined boundary, and are trying to integrate some of this thinking around activity space. But I think that's a great question. And in countries where there's not really good administrative data, we are facing that right now in the DRC. How can we sort of take this approach maybe to use this and sort of integrate with the systems that they have?
Thank you for a very nice presentation. You touched on sort of what was unique, or what you did was to look at the joint effects, right? So people looked at networks, they've looked at space, but they're not coming together. You comment on time as the third dimension there, because we have a lot of people who are migrants, migration, but also when you think of mobility physically as well as network, just wanted to get your thoughts on how you bring time effects.
Yeah, that's a great question as well. And that I think is something in terms of time, how we dealt with it, both in this study and in this study, again, it's going to be biased because it was self-report. We're really looking at the time exposed. But one of the issues that we've faced is that, at least with the studies we've done in New Orleans, you can know how fast someone's going and how much time they're spending in each location, right? But someone can be exposed to outlets, whether they're in a car or whether they're walking, right? And so I think having to take that into consideration as well when you're calculating your measures. And so that's been something that we've sort of grappled with and how to do that. In my study, we accounted for time exposed when we developed the risk or the measures. I'm not sure if that gets at your time question.
Actually, always change.
Oh, over time, yeah.
But restricting mobility is an age-old practice of putting groups of people in certain places.
Yeah.
Right? And they may be very networked, but you shall not be at this party down, etc. So just wanted to get your thoughts on that change.
Yeah, that would be, and that would be fascinating to study. I've done some work with not with activity spaces, but with predefined administrative boundaries and historical data, and looking at changes over time with that type of data. But with activity spaces, I haven't done that. And I think that would be really interesting to see how they evolve.
west. Red line.
Yeah. There.
So I apologize if this isn't a totally, but I appreciate it. So the methods of this are extremely interesting. But the implications of it can be, higher levels of penalization for folks because you're, calculating and capturing a lot of the behavior of criminalized behavior and specific moments in time. So from participatory angle,
Yeah.
what did you do to one, ensure that this data is protected? Two, to think about interventions that are not individual level interventions, especially ones that don't necessarily involve the state actors who might be the sole people that folks are concerned about being in criminalized by. And then three, what was the attrition like? Because this is a really, really complicated study and you only had 51 participants. So I'm wondering if you were able to calculate the attrition data to see if there were differences between the folks who could continue in the study.
Yeah. So I think that's a great point about some sort of, I guess, negative, or, I don't know if negative is the correct word, but sort of how this could actually increase their risk and that we're capturing, where they're going. So I think that that's a great point. In order to gain sort of the trust of the female sex workers, we did, formative research and we presented this whole idea to them and really tried to get an understanding if this would be something that they would feel comfortable doing. And it was really through that sort of trust building that, I think they became more comfortable with it. And then even after participating, they, came back and said, they asked me to keep doing the study. They wanted to keep doing it because I think it really made them, they were like, we never looked at street names before, and so it actually gave them sort of some awareness of where they are going and what's happening in their environments. But I think, I don't know if we thought enough about the negative implications of the study in terms of the harms that it could actually end up doing on the female sex workers. Yeah. And then, sorry, your second question. Oh, so we had actually really good, response rates. We had really high response. I think the daily diary was a 91% and the travel diary was 85%. I think that, in terms of attrition, I think it was actually overall how many people sort of stopped participating or only did one diary or something like that was only a couple people. And so, again, they liked this activity. It was learning for them. People like to learn. People, want to engage and participate in society. And I think they appreciated that.
Erica, this obviously very important work. My question is sort of piggybacking on what a couple of people here already mentioned about because we haven't shown any descriptive data, it's hard for us to assess any structural positivity violations, any structural overlap between networks and spaces. Are there enough people who fall within the 2x2 in all 4 cells when we have high-risk networks and high-risk spaces, but high-risk networks and low-risk spaces? Do you have some sort of a figure or some data to help us say that these effects are actually I also brought that up.
Yeah, I do. I'm sorry I didn't have them in here. I had to choose what I presented, and I didn't include that, but I do have that, and I'm happy to share that with you after the talk.
But Usha's idea of modeling context over time, I think, is super important. Of understanding, over time, how concentrated does disadvantage stay, right? And really identify those groups that experience time-dependent concentrated disadvantage. And so I just wanted to underscore the knowledge.
Yeah.
of that. And, some other fields that are doing arts and multi-level.
Yeah, I think in other fields, this is less novel than it was in the public health sphere. But I know in geography as well, they're doing more of that. Yeah, but that would be great to see those papers. Yeah, especially about the interventions.